Rahim. So next topic is ECG changes in hypokalemia. In the last topic, I have gone through the concept of ECG changes in hyperkalemia. Hypokalemia can happen because of like diarrhea and recurrent episodes of vomiting. That is gonna activate the RAS system. That is gonna increase the aldosterone, right? And there will be loss of potassium and hydrogen ion, right? And this is gonna cause the hypokalemia, right? And patient is gonna complain of weakness, right? So in the hypokalemia component, the death is because of diaphragmatic paralysis, right? But in hyperkalemia, death was because of diastolic arrest of the heart, right? So in this case, if we get the ECG done, so the first thing is we gonna find in ECG is inverted T wave, or there will be absent T wave, or there will be decreased amplitude of T wave, right? The second finding is that of ST depression, right? So along with that T wave, there will be ST depression, right? So we're gonna find ST depression in unstable angina. We're gonna find ST depression in non-STEMI, non-ST elevation MI, and we're gonna find the ST depression in hypokalemia as well, right? And the next finding is that of increased amplitude of P wave, right? In hyperkalemia, there was increased amplitude of T wave, but in hypokalemia, we're gonna find that there is increased amplitude of P wave, right? So this is called as pseudo P pulmonale, right? So if P wave height is more than 2.5 millimeters in the absence of pulmonary artery hypertension, we're going to call it as pseudo P pulmonale, right? Okay. And the next finding is that of prominent U wave, right? Okay. So you can see there is in this ECG there is increased height of P wave. You can see that there is T wave inversion. Along with that, you're gonna see that there is another wave that is called as U wave, right? So we're gonna see the prominent U wave in these patients with hypokalemia. There will be prolonged QT interval if T wave is present, right? So we're gonna say that there will be prolonged QT interval, right? If T wave is not present, and U wave is present, we're gonna call it as prolonged QU interval, right? When T wave is absent, we know that prolonged QT is going to predispose this patient to Torsades D pointage arrhythmia, also known as polymorphic ventricular tachycardia, right? And PR interval will be prolonged in both hyperkalemia and hypokalemia, right? Okay, so how we're going to treat this patient? We will have to give the injection potassium chloride, right? So it should be in diluted form, right? And we have to correct the potassium at the rate of 20 to 40 milliequivalents per hour, right? And when the potassium value is less than 3, right, 3 milliequivalents, we're gonna give the injection. We're gonna give the potassium in IV form. When it is normal value is 3.5 to 5.5. Once we have once we have corrected the hypokalemia, now it is more than 3, so we'll have to add potassium in per oral form, and it comes with the brand name of Neo-K tablet. Neo-K, right? 500 mg we can give in TDS, right? So that's all for hypokalemia component, right? So you're gonna remember that there will be decreased amplitude of T wave, right? And it can be absent, it can be inverted, there could be ST depression, there will be increased amplitude of P wave in these patients, there can be permanent U wave, and there is the unique thing about it is there will be prolonged QU interval, right? So that's all for today. That's all about the hypokalemia and ECG in hypokalemia.